To continue on in chapter 12, we're going to return to 12.5, the cerebellum. So looking at the cerebellum, this is the cauliflower-like structure that sits on the back of the brain right here. It is a cauliflower-looking structure. It's about 11% of your overall brain mass. And it's really, really important because it will process input from the cortex, the brainstem, and sensory receptors, mainly to be able to do smooth, coordinated movements. So this is very important in moving our entire bodies, moving our skeletal muscle to be able to have this refined, coordinated, and smooth movements overall. So that's what your cerebellum is going to be responsible for. In addition to that, it also plays a major role in balance in order to have those smooth, coordinated movements. We're not going to go into the specifics of the cerebellum, but what you do need to know is Purkinje fibers. So when we're talking about our Purkinje fibers, these are going to be specific to the cerebellum only. So this is where you will find these Purkinje fibers, and it's the specific type of neuron found within the cerebellum. So here's that cauliflower-looking structure that sits on the base of the spinal cord. So you can see that here as well. Again, the general anatomy, we're not going to look at in depth for this, but how the cerebellum actually processes our information. Again, it's smooth coordinated movement and our balance. So it's going to receive information from the cortex on our voluntary muscle contraction. It's going to receive information from the proprioceptors all throughout our bodies, essentially those that are going to be responsible for position and momentum and movement of our body. And the big thing is that it calculates the best way to smoothly coordinate all of our muscle contraction. So that's really, really important. And then it saves this blueprint so that way we know to do it in the future. So that's really, really, really important. So just some information about the cerebellum. So looking at 12.6, moving on to this part C, PowerPoints. 12.6 is looking at the functional brain systems, which essentially is going to be the remaining areas of the brain that are not the sensory or the motor, and how they all work together. So these are going to span multiple structures within the brain in order to produce some global function. So these are these functional brain systems. So the two we're going to talk about are going to be the limbic and the reticular formation. That's going to span multiple structures. So looking at the limbic system, so this is going to be primarily related to all of our areas that are responsible for our emotional regulation. So our limbic system is going to be in the medial aspects of our hemisphere and our diencephalon. And there's this one big tract that will be the fornix that will connect and link all of our regions. So this is mainly going to be our emotional brain, or it's our emotional response to our external stimuli. So most of our limbic information is going to be really responsible for this type of processing of our information. The two, some of the big structures that are going to be related to our limbic system. So our structures are going to be, the first one is going to be your amygdaloid body. So that's an important structure that is found as part of your limbic system. You'll also have your cingulate gyrus. And again, gyrus is going to be the bulge or the hill. It's not the groove. So this is a bulge that you will have, the cingulate gyrus. This is really important in expressing these emotions through any kind of gesture and resolving some of that mental conflict. So you can see how deep inside our brain, we will have this kind of emotional structure that goes from our cortex through our diencephalon. Here's the cerebral structures of your limbic system that kind of make up this circular pathway. And the fornix is the big connection through them all. So that's kind of the limbic system. It also puts our emotional responses to odors. So the example is a skunk that smells bad. Another example is your grandmother's apple pie. You know that smell. you start bringing up that emotional memory. What's interesting about the limbic system is that most of the input is going to be relayed through via the hypothalamus. So most of our limbic output, basically our emotional response, is going to be processed and relayed through the hypothalamus, which is responsible for a lot of our homeostatic mechanisms. So that's really important for how we get those autonomic reactions to an emotional response. This is the exact reason we'll have, a red face when we're nervous. Why we will get an elevated heart rate on a first date or a job interview is because there is a link between your emotional processing and your autonomic response. So that's a really cool information. This is important for psychosomatic illnesses. So psychosomatic illnesses are whenever there is a disorder that has a physical symptom that originates from that actual emotion. So it's the physical exhibition of the internal emotion. So that's why you can have this physical impact because of the emotional, is because of this connection to the limbic system through the hypothalamus. And then it also will interact with our frontal lobes. So that's where we'll find that higher level cortical thinking is in that executive functioning within our prefrontal lobes. So as a reminder, if this is our limbic system that is coming through the center of our brain and kind of doing this whole area, our prefrontal cortex is this part of our brain. So the interaction between the two is how we are going to be able to react emotionally to things that we understand that's going on. And it makes us consciously aware of our emotional environment and our processing. So that's really, really, really important. So as I said, we had our amygdaloid body and cingulate gyrus. To add a couple more structures to that would be this hippocampus. So hippocampus will also then connect to our memory. So this will be responsible for why we have those memory recollections from our emotional processing. It would be through the connection of the hippocampus. So that's important as well. And an hippocampus is a deeper structure. We don't really need to know where that is located. So within our functional brain areas, we also have our reticular formation. And so this is a really cool process. Essentially, your reticular formation is going to be through the center core of the brainstem all the way up that length and go through the hypothalamus, thalamus, cerebral cortex, cerebellum, and spinal cord. Basically, it runs through the length of the brain. So the reticular activating system, or the RAS, is the network between all of these areas. And what this activating system does is it allows you to process out and filter information. So this will actually filter out information. And what it's technically filtering out is it will filter out familiar information. So it will keep novel. And so what we mean by that is if you are sitting in a chair or you're sitting in your car on your way to work and the engine is running, you essentially notice the engine running when you first get in the car. 3 minutes down the road, your brain is no longer processing that the engine is running because of the sound. You've tuned out that sound because your brain knows that it's going, it's familiar information, it's not new, you're good to go, you can continue on with everything. So essentially you're going to filter out kind of that ongoing information. The same thing would be true for an air conditioner. If you're sitting in class and there's an air conditioner going, at some point your brain will start filtering out that information so you are no longer processing that sensory input. So that's really important in order to govern our arousal. So basically anything that is novel, the novel information will be what keeps our attention. So that's really important and really cool on how that works with this reticular activating system. And it does it to keep us conscious and alert within our environment. So as I said, it does filter out, so much so that it's about 90%, 99% of our stimuli is actually not relayed to our conscious. If you're sitting in a chair, your brain is no longer consciously processing the fact that you are sitting and that there's pressure from the chair. You just know that you are. So it's very interesting to see how that kind of repetitive, familiar stimuli is processed out of our brain. So one other thing with our reticular formation is that it will actually regulate some of our visceral motor centers. So this would be our blood vessels, our vasomotor centers, whether or not we can dilate or constrict our blood vessels, our cardiac center or our heart, and our respiratory center and our breathing. So this reticular activating system can regulate these. So you can see how it does actually come through the brainstem and then hit all the areas of the brain. Here's a review of some of the major brain areas that we have talked about. So those are the two functional brain centers. The next sections we're going to talk about are going to be our higher mental functions. So looking at some other things within our brain that are kind of our higher mental functions. So first off is going to be looking at our language. We're going to look at memory, brain waves, consciousness, and then a little bit of the sleep-wake cycle. So all of these are higher mental functioning. So if we start with our language, language is going to be responsible for a lot of association areas within our cortex, but it's also going to be primarily in the left hemisphere. So that's where you're going to find the primary information processing for language. Is going to be in the left hemisphere. There we go. So that's the important part for this. The two areas that we've already talked about has been Broca's area and Wernicke's area. So these are the two main language areas. As a reminder, Broca's is speech production. So that is here. This is the ability to create speech and produce language. So patients with a lesion in this area, they can understand, but they cannot articulate and create their own language. They cannot speak. And then the second one is going to be Wernicke's area, which is kind of way back here. And this is the ability to understand speech, but not be able to speak it yourself. So this would be patients with the lesion in this area would be communicating through blink once for yes, blink twice for no. They can understand you, but they are not able to articulate their own language. So these are very common. There's actually a loop that connects the two and is very common to have that be a place of injury for stroke patients. So that's pretty cool information on how language occurs inside the brain. And then we're looking at our memory. This is just going to be the storage and then the retrieval of kinds of information we have. So when we're looking at memory, we do have a couple different kinds. We have declarative, which is things that are facts, names, faces, words, and dates. But then you also have procedural, which is where you remember how to do a sequence of events, but you don't consciously think of what they are. This would be like playing that piano where you've got that procedure that you've worked at. But then you have some that are going to be just plain motor memory. So if you get on a bike, your legs will remember how to use that bike. If you haven't driven a car in 2 weeks because you've been on vacation and then you get in the car, you automatically know how to drive that car. So that would be that motor memory of motor skills. But then you also have that emotional memory, which ties in the hippocampus to the limbic system that we talked about briefly, which is where you will have the emotional the physical reaction to an emotional response. So it's those kinds of memory are all going to be housed and processed within the brain. So declarative memory, which is our facts, names, faces, words, and dates, there's two kinds. So you're going to have short-term or long-term. Short-term is working with temporary information that you're able to hold. So this would be someone giving you directions somewhere, holding on to a phone number, a grocery list, that you need to write down, giving instructions to someone on how to complete something, and then having essentially then writing it down later. All of that would be short-term memory. Whereas long-term memory is remembering something that you learned several years ago, long-term. It's got limitless capacity. So there's a couple things that affect our short-term to long-term memory. So your short-term needs to be consolidated into long-term in order to have these memories stick around. So there's a couple things that will actually keep this from happening, and that will be your emotional state. This will occur best consolidating from short-term to long-term if the emotions are balanced, if you're alert, if you're motivated, if you're surprised, if you're aroused. This is why people remember things in the heat of the moment, is because they're heightened. You don't really remember your average everyday going to the grocery store where things happen normally. You'll remember if there's a heightened reason behind. So that's an emotional state. You're actually going to be better at consolidating short-term to long-term memory if you are more motivated to do that, or slightly more aroused and be able to do that. You also have rehearsal. So this is just where studying will come into play. So this is repetition and practice. In order to study for one of these classes, a lot of feedback I have given y'all is to repeat things and write it out and draw it out, and essentially repetition, repetition, repetition. Well, in order to learn something and put it into long-term memory, repetition is key. This is why you play the piano for hours on end when you're a kid. This is why you study for hours on end when you are in school. So repetition is key to consolidating short-term to long-term memory. And then a couple other cool ways is association and our automatic memory. So association is where you connect pieces of information, and it's easier to remember things that you know. So you tie new with old in order to remember it. And automatic memory is where you're actually storing information that you are subconsciously aware of. So that would be some of those pieces where you know something randomly that you don't remember thinking, I need to remember this. This is where a lot of that trivia information for people who are skilled in this area will come from. They just really know and can pull things out of their long-term memory, but they did not make the conscious attempt to store it. So all of these structures of the brain are important with our memory consolidation. Hippocampus, cortical areas, our thalamus, and our prefrontal cortex are all really, really, really important. So when we're talking about the loss of these, so damage to these areas, specifically the hippocampus or surrounding temporal lobes, usually does result in memory loss. And depending on where that destruction is and where that damage is, will depend on what type of memory loss there is. So if you've ever heard of someone having anterograde amnesia, this is going to be our life happening here. This is just things are occurring, and here is going to be our point of impact. If we have some sort of point of impact that happens here, when we are talking about anterograde amnesia, consolidated memories are not lost, but you're not able to associate any old ones. So everything that is going to be happening before would not be remembered. So impact, whenever there's a moment with anterograde, you are able to remember after the event and on. So this is anterograde amnesia. You can only remember after. Everything that is before is forgotten. So there's two types of memory loss. There's anterograde amnesia and retrograde amnesia. So anterograde amnesia is the person who's living in the here and now, and they're essentially not putting any new inputs into their their brain. They're not remembering anything new. They're only able to remember all of the old. So everything from this point on, whenever they had the point of impact of whatever kind of damage it was, they are able to remember all of this. Anything that was before, they are able to remember, but they are not able to make any after. No new memories can be formed. Whereas when you have retrograde amnesia, they are able to remember all the after memories, but they are not able to bring up any information from the past and bring up those. So the difference between anterograde and retrograde amnesia is based on whether or not you can retain new or you cannot retain new memories. Okay, so to kind of look at the next section, which is going to be our brain wave patterns and our EKGs or EEGs. Brain wave patterns reflect electrical activity of higher mental functions. So whenever you're thinking about something or feeling an emotion, that's a very complex thing that's hard to measure. But brain waves allow us to do this. So an EEG is also called an electroencephalogram, and it records electrical activity that accompanies brain function. So anytime you think, sleep, have emotions, think of something you need to do, move a muscle, you're essentially creating an electrical activity in the brain. This is really important for research in areas and diagnoses, especially with epilepsy and sleep disorder. Those are the big ones. And the way it actually works is that they're going to put electrodes on the scalp, and it is measuring electricity, specifically underneath the scalp. So with these EEG, and they're also called brain wave patterns is another term that you'll hear. Everyone's brain wave patterns are unique, and these will change with a couple different things based on age, sensory stimulation, brain damage, whether or not you've had enough to eat, your physiological state, whether or not you slept well. So all of these are going to be measured with hertz. So they're going to be measured in frequency. So if you have a graph that looks like this is time on the x-axis. So you will have frequency, how often they occur on the y-axis. So these are all going to be sinusoidal waves. So they all are going to look like this. So basically this is going to be 1 second. So it's how many waves occur in this 1 second. And that's going to be measured as hertz or Hz. So it's the number of peaks per second. That is how you're going to move that. So the measurement of peaks per second are grouped into 4 classes: alpha, beta, theta, or delta waves based on how many peaks there are. So alpha waves are going to be 8 to 13 hertz. So I'm going to do this slightly different than your notes. So if these are our EEG waves and our brain wave patterns, we're going to do alpha right here, kind of in the middle. So this is going to be 8 to 13 hertz. This is where we've got regular, rhythmic, low amplitude. It's your normal, everyday thinking brain. So you're awake and relaxed. So this is going to be alpha. 1 second interval, you can see how right here, here's our second. That's our peaks. And then you're going to have your next one, which is going to be your beta waves. And this will have 14 to 30 hertz. So this is much faster. We're having more peaks as we have our 1 second. There's going to be more ebbs and flows. But then you also have theta waves, which is going to be the opposite. So theta is going to be less peaks. This is why I'm doing it in this order. 4 to 7 hertz. So there's less peaks. So if alpha is this, beta is this, theta would be this. So there's less peaks. This is really common in children and usually pretty uncommon in awake adults. And then the last one would be delta, which is 1 to 4 hertz. Or 1 to 3 hertz, so it's 4 hertz and less. And this is going to be sleep waves, where you are in deep sleep. This is also going to happen when there's an immune system, you're in brain damage under anesthesia. These are really slow waves. So if you're looking at these under just as a snapshot, here's our 1 second. We have alpha, beta, theta, and our deep sleep looping waves that go like this. Whereas our alpha is going to be our typical wave, our beta is going to be higher, and our theta is going to be slower than our alpha. So what's important about our EEG and our brain waves is that this is how we can diagnose epilepsy and seizures. So epilepsy is technically going to be a group of neurons that are going to have a lot of electrical activity at the same time. So essentially that's an epileptic seizure. This may result in loss of consciousness, falling, uncontrollable jerking, intellectual impairments. All of those are related because there's just essentially the brain is firing all at one time. And it occurs in about 1% of the population. There's a bunch of different reasons. So you can have a seizure and not be diagnosed with epilepsy. Epilepsy by definition is going to be 2 or more seizures. So that's kind of how the difference between the two. A lot of people will have something called an aura that will precede a seizure, and then two different kinds of seizures to talk about are going to be the absence and the tonic-clonic. So these had older names, but they've kind of been renamed and reorganized. So before we had the petit mal, now it is going to be called the absence seizure. And absence means there's no activity. It's the lack of activity. So basically, this is usually going to be seen as the expression that goes blank. There's just no emotionality, no movement, no processing. They are essentially absent. And then the other one is going to be a tonic-clonic, and this used to be called a grand mal seizure. And this is where there's going to be periods of losing consciousness, but there's intense convulsions, usually going to have periods of relaxation in between, or short bursts of relaxation that then go to larger convulsions. And this can result in breaking of bones, falling, causing concussions, biting of the tongue, loss of bladder and bowel. So these are the two new terms, is the absence and tonic-clonic, that you do need to know. So when we're looking at the concept of consciousness, what this is really just referring to is you are perceiving sensation. So you are aware of your processing of input. So you're essentially just aware of your sensations. It's not just happening to you, you know that they are occurring. These are usually going to be initiated voluntarily and controlled voluntarily, and they involve all of the integration with our higher mental processes that we've talked about: memory, judgment, emotions, all of those. So consciousness is you're aware of your sensations, of what is going on in your environment. Okay, so when we're looking at our consciousness, there's a couple times where we lose our consciousness, and that means that brain function is impaired. So typically, sleep is not considered unconscious, but when there is loss of consciousness, that does signal that brain function is not at its optimal level. So that can be a brief loss of consciousness, which is fainting, or that can be an extended period of unconsciousness, which is a coma. But either way, that is a signal that the brain function is impaired. So we are not going to dive into sleep for this section. So we're just going to go ahead and feel free to read through that. It's very interesting, but we're not going to focus on the types of sleep for this chapter. But all of our structures that we've talked about in our central nervous system, our brain and our spinal cord, are protected by the brain. So this protection of our brain. So here is our lovely brain we have going on. All the way around it, first off, we will have our skull that it is encased in. And then underneath your skull, there will be something that is going to be 3 layers. and a bunch of liquid. So you will have these protections. The 3 layers are going to be called your meninges. And meninges are the 3 layers that will surround your CNS, so it will cover your brain and your spinal cord. They do contain a liquid that's called the cerebrospinal fluid, and it consists of 3 layers. These 3 layers to your meninges are going to be the dura mater, the arachnoid matter, and the pia mater. So if we go from the skull, which is the most external, to the brain, which is the most internal, we will have 3 layers of meninges. The most external near the skull will be the dura mater. Dura means hard, mater means mother, so this is going to be the hardest external layer. Closest to the brain, you will have the pia mater. Pia means soft, so this is the soft mother. So this type of meninge will actually go into all of the grooves, all of the sulci, and all of the gyruses. It will actually be saran wrapped to the surface of the brain, whereas the dura mater will go over the brain. So then one in between is going to be your arachnoid. And it is called your arachnoid matter because it does look like this. So it kind of looks like a spider web. But that's because this meninge, this is where you will find your blood vessels that will then provide nutrients to the brain. So those blood vessels create a spider web appearance. So you can look right here and see that here is our brain, and all the way lining our brain is going to be this pia mater, and it is going in and out of all of the grooves, and it is going to essentially be saran wrapped to our brain. So that's our pia mater going in and out of all of our gyrus and sulci. And then the next one we're going to have is our arachnoid matter. And so the arachnoid matter, you can see, is this next layer. And underneath that is all of the blood vessels and the spiderweb looking appearance. So this is our arachnoid matter. And then the most external one, so you'll notice the pia goes into all the gyrus, whereas the arachnoid matter will just do the larger structures, whereas your dura matter will just essentially go across the actual surface. So it will just cover up the overall external surface and not go into the nitty-gritty holes of the bumps and the grooves. So that's the 3 layers. You will also have within this arachnoid matter your CSF. So there is going to be a foundation of liquid all the way around your brain. So your skull will be protecting it because it's a bone. You'll have 3 layers of meninges or connective tissue to protect it, and then your CNS will also protect it. So there's your dura mater information. And it will be dividing that essentially the nervous system, your brain, from your skeletal system in the external surface. I also have that arachnoid, which is the spiderwebby, which has your CSF. And then that pia mater, which will cling tightly to the brain following every convolution. So you can see those structures there. And then you'll also have the cerebrospinal fluid, which is a liquid that is a constant cushion around the brain. It gives the brain some of its nutrients, all of its nutrients, and it will carry some chemical signals, but it's also how the brain is able to maintain a consistent state around the entire brain. So it is going to be composed mainly of water from blood plasma with a little bit of protein and some ions, but it will actually circle around the entire structure of the brain. So through the lateral ventricles that we talked about, 3rd ventricle, 4th ventricle, and then it will rotate around the entire brain and down the spinal cord. So it creates a consistent environment that is bathing the entire brain. So that's really, really important. Where all of this CSF is produced is the choroid plexus, which is going to be found in the roof of the lateral ventricles, the right and left. And that's kind of all you need to know about the choroid plexus. But in general, in an adult, we will actually replace our CSF every 8 hours. We will have new. So this is where infections such as meningitis come into play, because that's an infection of the meninges, which is why sometimes this infection can happen very, very quickly, is because we need to replace our normal CSF every 8 hours. But if there's a high infection and that does not happen, that causes issues. So again, we're not going to focus on all of our production of CSF. Hydrocephalus is also another disorder that comes from CSF, and this is where you've blocked the circulation or the drainage. So rather than having the ability of the liquid to be able to travel around through the brain, down the brainstem, and around the brain, and down the spinal cord, essentially what it's done is it's blocked. And if it's blocked, it will essentially just pool. And if it pools, then we will create this pressure that will push back in on the brain. So hydrocephalus is going to be a problem for adults, is because if we have pressure pushing on the skull, then it will essentially just push back on the brain, which will compress our tissue and cause damage. But in newborns, because the skull bones are soft and not fused, that pressure allows for the bones to expand. So this is how you get hydrocephalus. So rather than being, here's our brain, here's our skull, what we get is here's our brain, and then our skull has essentially done this, because you now have this collection of CSF rather than just it circulating all the way around. So that's what's going on with hydrocephalus. How they treat it is they will actually put in a shunt, usually right here, and that will just drain out all of this liquid. Sometimes it needs to be a permanent shunt. Sometimes this happens every now and then. Sometimes it's a one-time thing, but that is how they treat hydrocephalus. There's also a structure called the blood-brain barrier that keeps the internal environment within our brain kind of safe. It's a protective mechanism. So substances that are coming from the blood, rather than just being able to travel around the brain and be hunky-dory, they must first pass through a filtration system that is a continuous endothelium of our capillaries before they can actually pass over to our neurons. So these are tight junctions, and essentially creates this impermeable barrier in our endothelial cells. And in order for anything to get through, as we know about an impermeable barrier, it then must go through the plasma membrane. So that would be done through simple diffusion or specific transport mechanisms. So the goal of the blood-brain barrier is that only things can get through. It's the least permeable cells in the body. So these are selective permeability for essentially the entire neurological system, not just for a cell. So that's really important. So what happens when some of these things go wrong with our injuries that we may have? So looking at our brain injuries and disorders, this is when things we've talked about can go wrong. So real quickly, we're going to hit some of the larger brain injuries that we usually come across in today's world. So the first one we're going to talk about is going to be concussion. We're also going to talk about contusion. We're going to talk about a hemorrhage and edema. So looking first at a concussion or contusion. A concussion is just a temporary alteration in function. So it's basically cumulative blows to the head. So this is really big with our sports environment right now. Anything football, wrestling, contact sport related, a concussion is just a temporary alteration in function. However, it could result in more significant damage overall. Then you're also going to have a contusion, which is when you have permanent damage due to some sort of injury. And this can then lead to a hemorrhage or edema. So those concussions and contusions can lead to the hemorrhage or the edema, but that's the difference between the two. Okay, cerebrovascular accident, also known as a CVA. These are typically called strokes. So a cerebrovascular accident is an issue in the vascularization within the cerebral hemispheres. So these are going to be our strokes. There's two types. You can have we're really going to talk about one here. So the ischemic stroke. An ischemic stroke is where you are going to have some sort of blood blockage leading to death of the brain tissue. So with an ischemic stroke, you essentially have deprived the brain of oxygen because you have blocked the flow of blood. If you've blocked the flow of blood, you've blocked the delivery of oxygen. So an ischemic stroke is depriving the brain of O2 for an extended amount of time. This will lead to tissue death. It will kill off. So tissues will start to die based on where they were blocked and not given oxygen. A lot of times this can result in the tissue dying in a specific place, can result in paralysis of sensory or motor deficits based on wherever that tissue death occurred. There's two main ones, the TNA and the TPA. A transient ischemic attack is where you're going to have a temporary episode of reversal ischemia. So this could happen through a couple different reasons, but it's not a full-on stroke, but it is where there's temporary blocking of your blood, so therefore temporary blocking of your oxygen delivery. Then you also have tissue plasmagen activator, which is how we actually are going to treat that. So that's a very important, TPA is very important for anything if you're interested in nursing, because you will use that a bunch. Okay, we're going to talk about 3 progressive degenerative disorders. So the 3 top degenerative brain disorders that are kind of in our common culture right now are going to be Alzheimer's, Parkinson's, and Huntington's. So we're going to start with the first one, which is going to be Alzheimer's. So not all timers. It's usually older people who get it, but it's Alzheimer's, not Alzheimer's. So this is a progressive disorder that results in dementia. So it will lead to loss of memory. You can have dementia separately. So you can have dementia without Alzheimer's. But Alzheimer's will always result in dementia. It's about 5 to 15% for people over 65. So it does increase as you get older. And some of its symptoms are memory loss, a short attention span, disorientation, moodiness, confusions, hallucinations. And what is happening with Alzheimer's is there are 2 things that we know. So with Alzheimer's, it is going to be related to proteins misfolding in the brain. So remember we said that if you change the structure, you will then change the function. Well, Alzheimer's has been related to proteins being misfolded in the brain. So these are going to be called neurofibril tangles. So essentially the proteins have gotten all tangled up and they no longer look the way they should. So they are just allowing for dementia to occur because they're not able to have the protein function the way it should. So these proteins are misfolding that causes a neurofibril tangle, but it will also be the buildup of plaque or peptides, amygdaloid peptides in the brain. But you'll hear plaques as the term of what they are occurring. So you essentially get buildup, and this buildup will block memories from being formed and from functionings to occur. So with this Alzheimer's, you can see how if we tangle up our proteins and we block due to the plaques in the brain, then we actually decrease some of our brain activity. So that's Alzheimer's. The next one is going to be Parkinson's. So Parkinson's disease is also degenerative, but what it's actually degenerative of is it is degenerative of dopamine releasing neurons within the substantia nigra. So it is going to occur in one spot. So we know that Parkinson's is going to be in the substantia nigra. And what it is actually doing is it is going to decrease dopamine releasing neurons. So the way it will actually do that is these dopamine releasing neurons are no longer going to be operating the way they should. So in the substantia nigra with our dopamine releasing neurons, it'll essentially deprive these guys, they'll stop forming and they'll stop working the way they should. And so if this kind of starts happening, you will have a decrease in dopamine. And if you have a decrease in dopamine because you've stopped forming your dopamine, so you've degenerated, stopped forming, you'll have a decrease in dopamine. You will have an overactive substantia nigra, resulting in tremors and at rest. So your basal nuclei will have too much activity because it doesn't have the dopamine to tell it to calm down. So how they actually treat this is with something called L-DOPA, which is a chemical precursor to dopamine. So if there's low dopamine, they give them essentially an artificial dopamine in order to stimulate these neurons to release dopamine. So Parkinson's is a structure of the brain that essentially will stop functioning, specifically the substantia nigra. And then the third one is going to be Huntington's. So Huntington's disease is also a degenerative. And what Huntington's is actually going to be specific to is it will be related to a Huntington protein. So they have actually figured this out. The Huntington protein. And what this is going to do is this will actually accumulate. So if you accumulate this Huntington protein, and then it will then die. And when it dies, it will then kill tissue. So we will not lose something, we will essentially accumulate something, and it will die off our tissue. So Huntington's is going to be degenerative, usually is fatal within 15 years of onset. So this one's interesting because there is right now some drugs to be able to block it. It is one of the longer diagnoses of only being fatal within 15 years. And so there's a lot of research in this area to try and lengthen that time frame as well. So when we're actually assessing all of our CNS functions, some of the major tests that will be done in order to diagnose these will be some reflex testing that we'll talk about in a later chapter, CT, which is computed tomography, MRI, magnetic resonance imaging, and PET, positron emission topography, to be able to look for some of these areas. So that is wrapping up chapter 12.5 to 12.10. The last section, 12.11, will be covered in a separate video.